Hi, everyone, and welcome to the Otolaryngologic Clinics podcast series. I'm Stacy Eastman, the managing editor for the series here at Elsevier. Otolaryngologic Clinics is a bi-monthly publication consisting of review articles focused on a central topic. Today, we will be discussing the December 2023 issue dedicated to otolaryngologic trauma, guest edited by Dr. Sydney C. Butts. Here now is our consulting editor, Dr. Sujana Chandrasekhar, to lead the discussion.
Hello, everybody. I'm Sujana Chandrasekhar. I'm the consulting editor of Otolaryngologic Clinics of North America. And today I'm speaking with Dr. Sydney Butts, the guest editor of the December 2023 issue of Otolaryngologic Clinics of North America, which is on otolaryngologic trauma. Dr. Butts is interim chair of the Department of Otolaryngology at SUNY, or the State University of New York, Downstate Health Sciences University in Brooklyn, New York, where she is also associate professor and chief of facial plastic and reconstructive surgery at the main campus and at Kings County Hospital Center. For our listeners who do not know, Kings County Hospital is a level 1 trauma center and sees over 150,000 visits in the emergency room every year. And for those who don't know or who never watched Welcome Back, Kotter, Brooklyn is the 4th largest city in America, and it is a borough of New York City. So this issue of clinics covers evaluation and management of various types of traumatic injuries in otolaryngology in 15 beautifully written articles. You can access the full issue as well as individual articles at www.oto.theclinics.com and hopefully in your institutional and personal libraries as well. So let me set the stage for this discussion by pointing out that the global burden of disease for facial fractures is really high. There are 7.5 million new facial fractures per year in the world. The most common causes are falls, motor vehicle injuries, other mechanical forces, and physical violence. There are significant and upsetting regional differences as well. Terrorism is a prevalent cause in North Africa and the Middle East, while firearms injuries are common in the United States. Globally, facial fractures caused 117,000 years lived with disability in 2017, with a disability rate on average of 6.5%. That means that on average, each person with a prevalent facial fracture lost 6.5% of their normal health status, with the disability, of course, being higher in middle and lower income countries rather than high income countries. So this is a really big problem. Knowing how to care for these patients in the most efficient manner will greatly help restore their appearance, functionality, and quality of life. So with that long-winded introduction, I'm so excited to say that I get to speak to my colleague and my friend, Dr. Sydney Butts, for the next little bit on a subject that she knows backwards and forwards. Welcome, Sydney.
Thank you, Dr. Chandrasekhar. I'm really honored to talk to you tonight about this, and really pleased and gratified to be able to have worked on this issue with you, and really honored to have been able to encourage so many of our colleagues to contribute to this important topic, because, I think as I talked about in the my forward to this issue, the treatment of head and neck trauma is something that I think is a really important part of the care that otolaryngologists, head and neck surgeons offer to the general public. No one leaves their home or gets out of bed in the morning expecting to be the victim of an injury that lands them in the hospital needing acute care. And so I think, for me, it's an important and very rewarding aspect of the care that I provide as a surgeon. And I think for every author who contributed to this, they feel similarly. And that's why I'm like so deeply respect these colleagues. Most of them I know personally. We're, like you said, we're friends and colleagues. We teach about these issues and lecture about them at meetings. And I think also hopefully encourage residents to see the importance of this too.
Thank you. Beautifully put. Sometimes we talk about every single article in an issue, and sometimes we talk about global aspects of the issue at hand and then pick out some certain topics to talk about. So I will encourage our listeners to go back and look at this issue, because there are in-depth articles on 15 different subjects here. But we're going to talk about a significant majority of those in the next little bit. So let's talk about the nose. See, as plain as the nose on your face, right? So what features of a nasal fracture are most associated with the need for future nasal procedures after a closed reduction?
I'm glad we're starting with this topic because, I think as most of our audience knows, nasal fractures are the most common facial fracture that most otolaryngologists will treat, and it's for the obvious reasons, right? It's a prominent structure, protrudes from the face, and it's therefore it's absorbs and takes on blows either from a motor vehicle accident, interpersonal violence, falls, things like that. So I felt it was really important to have a focus on this, because I think unfortunately sometimes something that's common, people feel that common equals straightforward, and that's not always the case. Luckily, many nasal fractures do not require surgery. Many are non-displaced, they'll heal on their own and be fine. But it's like anything, the best opportunity for treatment is the first opportunity, I think. And this is true in adults, but especially in younger patients, in the growing phase. And in the article by Dr. Trujillo on this topic, he addresses that also. I think, we can talk about that a little bit, but, the success of treatment of nasal fractures begins with identifying the people that do need surgery, right? And understanding um, when you need to make those decisions, because the treatment window is short, right? In adults, it's we typically say 7 to 14 days is when you want to get them into the operating room before the fractures start to heal. But in children, that therapeutic window is shorter because they're geniuses at healing, and they heal much more rapidly than adults. So once you've made the decision to do a closed nasal reduction, and typically, as Dr. Trujillo really lays out well in his article, it's two main things, right? It's if there's a new onset nasal obstructive symptom, or a change in the shape of the bony dorsum, typically a deviation or kind of a flattening or depression. Those are the things that should signal the alarm, like we're going to have to do something here. And then, I think another interesting issue, kind of leading into what happens after treatment, in terms of the diagnosis too, is, like, do I need to send this patient for imaging, right? Do I need to get an X-ray or a CAT scan for someone that I think clinically has a nasal fracture? And many of us feel that, this is a clinical diagnosis in part. We know that the sensitivity of plain films is not as high as we would like it to be able to like rest our hat on that. Many more and more, especially if you go to an ER at a hospital, you may just get a CAT scan because people want to be sure that there's nothing else going on. But I think in general, if the clinical signs and symptoms point you in that direction, I don't think an X-ray is needed. It's not mandatory, but it certainly can help support if there's some ambiguity. And so then once you've made the decision to do a closed nasal reduction, I think that the patients who do best are ones where the fractures, limited to the nasal bones, and or there's some involvement of the septum. Maybe it's dislocated, but it can be easily kind of reduced back into midline. I think the patients that have a harder time or may need something more later are ones where there's more extensive fracturing, especially if the fracture of the septum involves the L strut, so if the caudal septum is involved, if the dorsal strut's involved, it can be harder to kind of maintain the reduction with some of the simpler techniques that we would use closed. And I think also if a patient has a more comminuted picture of the bony dorsum, there are patients that I see that I sometimes counsel that, I think that the chances of needing something more in the future are much higher. And I think that's an important conversation to have up front so they don't feel that somehow later on they weren't prepared for that.
So I think that's a really great comment. As you said, nobody wakes up thinking, "Oh, I think I'll go and have some facial trauma today," right? So
right.
they're already shocked. I saw a patient
Right.
in the office today, just related and unrelated, was driving along and somebody ran a red light, and he ended up with a big ankle fracture, tendon injury, etc. And this was, almost a year ago now, and he's still really anxious and claustrophobic. And, when bad things happen to you, there's a huge emotional response. And certainly when bad things happen to you and it's right in your midface, and you have all these concerns about how you're going to end up healing at the end. And I think the counseling of, we're going to do as non-invasively but as aggressively as we can. But as you said, if the dorsum is displaced, if there's too much comminution, you may counsel very differently. And I think that's really important. So sometimes somebody has a fracture, has it reduced, they end up not doing well, either cosmetically or functionally or both. And I know you included an article on the management of complications and secondary deformity after midface orbit and upper third maxillofacial fractures. And that group, unlike the Trujillo group, which is from New York, was from Richmond, Virginia. And the reason I'm pointing out geography is that we all know that different things happen in different geographies, whether there's high speed, car lanes, whether there's an incidence of falls or firearm injury, unfortunately, in the United States, or, various ways that people injure each other. So how does one identify and then manage those sort of delayed scenarios?
I'm glad you brought up geography, Dr. Chandrasekhar. I can tell you that my trauma practice has evolved over the years. I spent the first 4 years of my academic life in upstate New York, in Syracuse, and I was on the faculty at SUNY Upstate. And I really
Go
that formed
Orange.
the South State. Yeah, that's right. that time formed the foundation of my trauma learning and understanding. And I had excellent mentors there who are for sure leaders in our field in facial trauma, including Bob Kellman and Scott Tatum there. So, that was a very important part of my learning and development, but the trauma demographics were very different. Anyone who knows SUNY Upstate Medical Center in Syracuse knows that the hospital is literally right off of I-81 major highway interstate in New York. And so the types of traumas that we saw there were different. It was much more high velocity, high energy, motor vehicle related accidents, many more outdoor types of things because of the, like nature of living in that part of the country. And so that differed from some of the types of trauma I see now living in Brooklyn, which is less high energy because there aren't big interstates going through Brooklyn, New York. So fewer motor vehicle accidents, more, not less significant necessarily, but more low energy. So more kind of interpersonal violence, problems, falls in the elderly, sports injuries in, kids. And so that, that certainly impacts the severity and complexity of some of the types of like bone and soft tissue injuries that you see. And I think it speaks to, and Dr. Lee's article, it's a magnificent, just display of the work that he and his team are able to accomplish in patients who have some, devastating injuries that they've seen there. But the kind of dealing with these types of injuries, these are patients who may, because they have other life-threatening injuries, if they have intracranial injuries, if they have, many of these patients have polytrauma. The facial trauma may not be the highest priority injury that they have to deal with. And many of the patients that I take care of in Brooklyn, it's more isolated head and neck trauma. And so oftentimes they can be cleared of any other comorbid problems. And then we are able, the otolaryngology facial trauma team is able to then step in and manage the issues. But, there are patients who have life-threatening injuries and the facial trauma has to wait. And so that may be a reason why someone's care is delayed. There may be delays in presentation. I mean, as hard as it may be to believe this, there are sometimes patients who underestimate the degree of the injury that they've suffered. And they think, oh, well, I'm just kind of swollen, maybe I don't need to go in. And then they realize that once they start to have functional problems, they need to seek care. So those are some of the circumstances in which someone might have a delay in treatment. And in that case, then your ability to offer treatment that you would acutely is then limited too. So you need to be familiar with the acute tools as well as the thinking around, what do I do now that some healing has happened, so I don't burn any bridges for what I need to do later. And then, as you said, Dr. Chandrasekhar, have a conversation with the patient about like what we do next. Yes, so it's very important to understand those things. And again, we're lucky because we have more tools now to help us in the kind of reconstructive process for someone who may have a delayed injury. For nasal fractures, it's the tools of rhinoplasty, right? Which are used in so many different circumstances. But I'll tell you that many of the rhinoplasty patients I take care of are post-traumatic patients. And so using those principles has been, is extremely applicable. And then in other parts of the face, having, high-level CT scan imaging that can provide 3D imaging, that can provide us with tools like virtual surgical planning, which Dr. Lee wrote about in his article, so in such an amazing way. And another article that focused on this is Oswaldo Enrique's article. So Dr. Enriquez is from Emory, and he talked about the use of virtual surgical planning, 3D printing, and intraoperative CT, these are all amazing tools that help us be more precise in what we're doing in these kind of delayed chronic fracture pictures.
And I think there's, like you said, these articles are really wonderful. There's beautiful drawings, there's beautiful intraoperative and pre and postoperative pictures, but there's some really interesting tables. And I think, for example, the table in the article on managing complications after midface injuries by Dr. Thomas Lee and colleagues from Virginia, they have a table 4 that says early, late, and post-op complications of nasoorbital ethmoid fractures. And I think these are really very important for the student, the resident, but even the experienced otolaryngologist who may not be dealing with facial trauma all the time, like me, to know about. So, for example, early things to worry about are anosmia, epiphora, visual disturbance. If you suspect a CSF leak, obviously, if there's some telecanthus, if the midface is pushed back or has retrusion, and if there's telecanthus, right? So these are early signs, but these are something that should alert you that there's something much more going on than perhaps meets the eye.
Well, right. I mean, these are for sure the red flags. This is a great table. Circling back to what we were talking about with respect to nasal fractures, I mean, this table is really helpful for people to refer to in making the distinction between a patient that has an isolated nasal fracture and someone that has something much more. So if you see any of these symptoms from table 4, in Dr. Lee's article, you'll say, wait a minute, maybe this is the person that does need a CAT scan, right? Maybe this is someone who has more extensive bony and also soft tissue injuries, right? Because we know that the bony disruption is significant, but the soft tissue issues that go hand in hand with these and also lead to some functional problems need to also be appreciated. And that's where the CAT scan and other imaging modalities may be of help. Yeah, those are the clinical judgments that I think, in referring to these articles will allow facial trauma surgeon to have the right types of kind of conversations, even with emergency room colleagues, right? About making decisions. We're all in healthcare trying to make these smart decisions about utilization of resources. Does every person that has have a trauma to the nose need a CAT scan? No, maybe they don't even need plain films, but the decision making and the judgment around those choices should be guided by this type of clinical understanding, right? And that's just, back to what we all, the foundation of what we learn as doctors, right? The exam. And then, Dr. Chandrasekhar, what you were saying before about the mechanism, right? I'm much more worried about these types of red flags in someone in a high energy MVA than I am maybe in someone who got hit in the nose with a soccer ball. I'm worried about, all those, but I'm thinking about things a little bit differently when the mechanism directs us to consider something more.
Unless, of course, the soccer ball was kicked by Ronaldo or something like that.
That's okay. Lionel Messi, right?
Yeah, if Messi's kicking the ball into your face,
yeah, watch out.
You mentioned virtual surgical planning, and I find it to be such a cool adjunct because in the very beginning, when we used to talk about 3D reconstructions and virtual planning, it seemed to be adding a ton of cost and, monetary and time without necessarily showing outcomes. And now I think it's almost counterintuitive, but doing the extra work actually costs less monetary time and the unfortunate consequences of poor outcomes when you do this early planning. So can you talk to us a bit about how and when you do this and how involved it is?
So I agree with you. I think virtual surgical planning and the utilization of CT scan technology that helps print and make plans has been an incredible addition to the armamentarium of what we do. So I think the reason that it has been helpful in like all the metrics that we think about in terms of wanting surgery to be better, meaning decreases in operative time, more precision in terms of like the way we achieve reduction, things like this. Fewer returns to the OR for revision surgery. Plus, so those things aside, which are all things we want for our patients, there's another upside because the time in the operating room is shorter because more time is spent outside of the operating room in planning. And in one of the ways that that's best shown is the idea of making custom implants and custom hardware for the patient. So, when we're doing facial trauma, a fair amount of time is spent in adapting plates to the fractured bone. And that requires using benders and pliers and things like that because there has to be an excellent fit between the plate and the bone so that the construct is appropriate, right? So there's no no ability for there to be any additional mobility. That takes time, especially if you have a comminuted mandibular fracture where you have to bend a large, thick reconstruction plate. That adds time. That's time that you're using while the patient's under general. What if by doing that outside of the OR before the case, you spend time. So the way this works, and the teaching sessions, they're so interesting, right? It's a great learning opportunity for residents. And I mean, for me, like for my colleagues, we sit there, we talk, we brainstorm, but it's really great for residents to understand planning, and it really models like what we want them to be doing, which is, understanding that the the fun part of surgery, of course, is the actual procedure, but the work of surgery happens before you enter the operating room. And I think virtual surgical planning as a process really emphasizes that. So what we do, and what Dr. Enriquez highlights in his article, is you send a copy of the CT scan to a biomedical engineering company that's associated with one of the implant companies, and you have a virtual surgical planning meeting. It's done virtually with the biomedical engineer, with your team. And they sit there in real time, and they manipulate the image, the 3D image for you, to show you how you're going to move the bone, where the reduction should be, where the plate should be. They will bend that plate for you in real time, and then they'll create the plate for you so it's ready for you in the OR, so you don't have to do those things. The other thing that they do is they make drill guides. So they will place on the bone, while you're doing your planning, exactly where you want to drill the holes for the plate, so that you avoid important structures like tooth roots, like the mental nerve, if you're working in the mandible. Again, all of these are things that it just takes some of the mental energy out of what you're doing intraoperatively. And that for sure is a time saver. In Dr. Enriquez's article, he has a great figure. It's figure 6, where, so that's, using the skills to create plates and precisely know where you will put screws in, so you don't have to think about it. But then the other thing that can be done is the creation of patient-specific implants. So there may be situations where his case shows a zygomatico-maxillary complex fracture, right? So a zygomatic fracture in the midface. And the team in this case decided that to reconstruct this patient, what they would do, instead of trying to reduce the chronic fracture, they would camouflage the deformity by creating a custom implant for this patient and placing it over the zygoma to deal with the depression that had been created by the displaced fracture. So the virtual surgical plan can then come up with a precise implant just for this patient that fully compensates for the bony and soft tissue losses. And they create that, and they send it to you in the hospital, and then you implant this into the patient. It's an amazing technology.
You never reduce or push forward that depressed anterior face of the maxilla. You just
You don't have to. If you've made a decision that you want to just camouflage it for whatever reason, right? The patient may say, you know what, I don't want the risk that comes with this, I don't want the prolonged surgery that would come with, trying to reduce a chronically fractured piece of bone. And if there's another way that you can do it, let's try that. So again, this opens up an opportunity for shared decision-making, right, with patients, if this is what they would prefer.
And then,
But you can't do that, and virtual surgical planning can help you with that option as well. So there are a number of ways that you can approach these, and to have those options, and then to be able to say to the patient, we can do it this way, or we can do it this way, and let's talk about the risks benefit profile for each.
And I think, pardon my ignorance, but when you think about it, like, let's say medially displaced zygomatic complex fracture with the anterior face of the maxillary sinus pushed in. You think about, of course, infraorbital nerve compression, but you think about exposure of the sinus lining and the sinus cavity to whatever your implant is going to be, whatever your repair is going to be. You think about, negative pressure in the sinus that maybe pulls the floor of the orbit down. Like there's a whole bunch of physics that comes into it. So I think as I was reading the articles in your issue, it's really, really neat, the understanding of physics and the properties that go along with midface trauma that have really evolved over time to make this a much more perfect result with much less chance of a delayed secondary or tertiary such complication.
So first of all, the demographics of who gets trauma, who's exposed to trauma, it's bimodal, right? It's young people, right? 20s, 30s, and at least in the US, more often men. And then now what we're seeing in the United States is we're seeing a second mode, and that's at the other extreme of age in older patients over 65. So I think, in terms of thinking about ways that we can offer surgery to patients once, hopefully, there are compelling reasons in both of those groups, right? In the younger group, it's because even though they're young and they're healthy and they often don't have many comorbidities and can sustain surgery better, they also have, if they they avoid some of the risky behaviors that maybe led to the trauma, they have maybe 50 or 60 years of life left ahead. And so the things that we do as trauma surgeons that hopefully restore form and function should be built to last for maybe 50 or 60 more years. And so being thoughtful about that, like even the placement of incisions, right, on the face. I think sometimes there's this thought, well, it's a trauma patient. We just let's just get it back together and whatever. No, these are patients who care very deeply about what the final outcome will be. And I think the idea of doing everything you can to make that as camouflage incisions as well as you can, restore everything, and in a very thoughtful and careful way, I think you will have, if the patient does well and heals well, you will have someone who is grateful to you for life. So those are, I think, some of the concerns too in a younger population. And then in an older population, and again, this is why I thought it was really important to include an article on geriatric trauma. And that was co-authored by several amazing clinicians. What I like about that article is that it truly was, it pulled in people from different parts of the country. So we have one of our senior authors, Michael Noir, is in Seattle. Then another one of our senior authors, my good friend Sharon Bragman, is in Syracuse, and she's the chair of geriatrics there. So she's not a surgeon, she's a geriatrician. And then my other good friend at UConn, we brought people from different parts of the country together who all look at older patients from a different point of view, right? One's a head and neck trauma surgeon, Dr. Noir, Dr. Bragman's a geriatrician, Dr. Parham at UConn, he what is the former past president of the American Society of Geriatric Otolaryngology. So all these people are very thoughtful about this. So when you're thinking about trauma surgery in an older person, you also want to think about, how do I operate on this person in a way that minimizes their exposure to general anesthesia, right? We're all much smarter about the cognitive insult that happens in an older person who has to be under general anesthesia for a long amount of time, and some of the perioperative issues that they go through from the trauma itself, from the actual surgery. And so we want to minimize their exposure to surgery, and we don't want to have them come back. So I think these additional tools that allow us to plan and be precise offer a lot of benefits to the precise two groups of people who are maybe most vulnerable to trauma. And so I think that's what's wonderful about these tools, right? That they're helping us to minimize some of the perioperative issues, and attain the healing results that we want based on the priorities of these two groups.
Yeah, I think that article that you mentioned about trauma in the aging population had some really neat resources. There's a figure 1 that shows the difference in sites of fracture for geriatric trauma patients who are in the geriatric age group who sustain facial trauma versus younger people. And I think that's really important because if you approach everybody like, oh, I'm going to expect X, Y, and Z, well, you may expect actually, Q, R, and S in this population versus that population. And then there's some really outstanding flowcharts and tables on frailty and medical risk and post-op management and delirium, which I think, we don't stop being doctors just because we know how to fix your face, right? And that's really, really important. On the other end of the age spectrum, you've also included some articles on mandible fractures in children versus adults. And I think that's really important as, the children clearly, as their jaws are growing, their teeth are coming in. Can you talk to us a little bit about the keys to avoiding complications in mandible fracture repair, and how those complications are different in children versus adults?
So I'm so glad we're talking about this because I think that the thinking around some of the reconstructive choices in children, it really requires a almost having a crystal ball or thinking in that way, right? Because you have to think about what you did today, but you also have to think about how what you do today is going to impact this person maybe 10 years from now. And it has everything to do with the fact that you're operating on a growing face that's changing, and that's the thinking that I think makes the reconstructive decision making in the pediatric patient both challenging but also important. And there's a saying, right? Children are not little adults. It's quoted a lot because it resonates. The article on pediatric head and neck trauma was written. The senior author on that is Dr. Lisa Morris, who's at LSU. Lisa is a fantastic surgeon. She also did did 2 facial plastics fellowships because that's her.
One is really just only one.
Yeah, she couldn't get enough. She did her first facial plastics fellowship in Syracuse, where I did mine, and then went on to do more training in craniofacial surgery that's seen with some congenital anomalies like craniosynostosis and things like that. And so, she was someone that I knew would be the right person to talk about this. So in thinking about children and facial trauma, but specifically talking about the mandible, there's several things, right? The mandible in a child is very different. And aside from the obvious that it's smaller, but the subsides of the mandible are different. The gonial angle is more obtuse in a child. You have to think about, that there are tooth buds everywhere. So that plays a role in how you would even think about applying hardware, whether or not you can leave that hardware in. So I tell my adult patients, we don't necessarily have to remove this hardware because once the bone heals, it's titanium, it's it's safe, it can stay there for a long time, it's MRI safe. But you can't exactly say the same thing in say, an 8-year-old, right? Who, if you leave a titanium plate there while their jaw is still growing, could result in a growth restriction. So sometimes conversation in that age group has to be, we may be meeting again after the bone has healed to remove this implant so that there isn't a set of secondary problems. So that's one issue in terms of the thinking. The other issue is that, interestingly, sometimes in children, less is more. So growth of the mandible actually can be your friend, and it can be harnessed because there's such amazing bone turnover and growth, and the remodeling that's happening because of growth can mitigate some of the fracture issues, especially if they're mild. So sometimes applying the principles to a child that you would in an adult can actually cause new problems. You don't want to, strip a lot of periosteum off because that's a site of growth or that's a driver of growth. And so sometimes more non-surgical approaches, meaning not open reduction, internal fixation, will be the better way to go. And sometimes more conservative options like just arch bars, brief periods of maxillomandibular fixation will get you where you want to be, meaning good function, good occlusion, things like this. So I think that's where children differ from adults in terms of some of the procedures that we talk about. And so I think Dr. Morris really lays that out really well in her article.
One of the things we talk about to patients is that the mandible is the hardest bone in the body. The temporal bone, of course, my bone, is the densest bone in the body, or the otocapsule portion of it. But the mandible is the hardest bone in the body. And I see that titanium, sort of tried and true, but you're also talking about the use of resorbable plates in these patients. And what you do if the fracture is through a tooth line, and when do you, in an adult, when do you leave that tooth, when do you remove that tooth? But let's talk a bit about when you would choose a resorbable plate versus when you might choose a titanium or a more permanent plate.
The polymers that are used to make resorbable plates have really, again, just added to the armamentarium of what we are able to achieve. And I'd say that use of resorbable plates has been extremely useful in the midface. When you think about mandibular fractures, one of the things that we know is that the loads and the forces that are generated by bite are significant in the mandible. And that's why there are more complications in mandible fractures and in midface fractures, right? Because the mandible is the mobile part of the craniofacial skeleton, and the muscles that attach to it to achieve movement are very strong. And so that's why the kind of goals of immobility in the mandible are so very important. And so I think the literature around use of resorbable plates has focused much more on the midface and the cranial vault, where the forces and loads are different. To my knowledge, there hasn't been FDA approval of using absorbable plates for mandible fractures, at least alone. I think where people have found some benefit to the use of resorbables is perhaps in conjunction with a period of rigid maxillomandibular fixation, so that there's immobility from just having the jaw wired shut, and you also have a resorbable plate there to kind of continue to help stabilize a fracture after maybe you take the patient out of MMF. But I think for the midface, it's been extremely helpful. I've used resorbable plates for midface fractures in children. Again, I think I would use it for a fracture that's less severely comminuted or displaced, where there there's less, again, there's less disruption of soft tissue and bone and things like that. But the beauty of this again is that you don't have to worry about removal. The body will resorb these plates over a period of months to sometimes a year or more. So that's an upside that helps us in the management of the growing phase because we don't have that worry about a rigid structure that can cause other problems.
I just want to take a quick pause here to let our listeners know that they can receive an exclusive discount on the issue we are discussing today by visiting us.elsevierhealth.com/expert.
I'm Sujana Chandrasekhar. I'm the consulting editor for Otolaryngologic Clinics of North America. And today I'm speaking with Dr. Sydney Butts, who is the interim chair of otolaryngology head and neck surgery at SUNY Downstate Health Sciences University in Brooklyn, New York, about her December 2023 issue of Otolaryngologic Clinics of North America, for which she was the guest editor. The issue is focused on otolaryngologic trauma, and you can find the issue and the individual articles at www.oto.theclinics.com and hopefully also in your institutional and personal library. That's also where you can find any extra content for any of our issues of clinics. In this issue of clinics, Dr. Butts and her colleagues, Drs. Cochran, Gottfried, Chernachenko, and Walvekar, have included a video to accompany their article on traumatic injuries of the parotid gland and duct, and it's pretty cool. So I recommend that you go by and watch it. You can also find one podcast per issue of clinics since 2017 at that website or wherever you get your podcasts. So, Sydney, Dr. Butts, I am very excited to talk to you about your article on parotid injury. And I'd like to hearken back to what we were talking about previously, because we've been talking a lot about bones, but proper handling of soft tissue and associated soft tissue elements is really very vital. You know, you mentioned that you've got to take care of the scar, you've got to do what you need to do to make that patient, when they present their face to the world, which is the first thing the world sees about us, no one's paying attention to that scar that you have carefully camouflaged or that soft tissue that you dealt with so gently that there's no roughness to the healing. So your parotid injury article has a lot of pearls in it. And one is that repair techniques are determined by the zone of injury, which is A, B, or C. So can you explain to our audience what that means?
Sure. So this is an article, again, that was really a team effort. And I want to recognize my colleague from LSU, Dr. Walvekar, who is the person who submitted that really great video, which shows how a stent system that he developed can be used in the repair process. And I'll talk about that in a minute. But, you know, Dr. Chandrasekhar, what I think for me is also what's so valuable about what the authors in this issue have contributed is that some of these injuries are rare, right? I mean, luckily, right? Thank goodness. But they are the kinds of injuries which you have to be able to recognize and fully assess the extent of the injury so that you don't miss something. And I think that's one of the take homes in this article. There's another fantastic article on soft tissue kind of emergencies. That was the senior author on that's Dr. Charles Woodard from Duke. And he has some examples of very extensive soft tissue injuries. Like he's got a picture with an auricular avulsion, right? You know, the management of that, very time sensitive, very important in order to try to salvage whatever tissue is available and also, you know, have these important conversations with patients. So I'm really grateful to him for including that. But so with parotid duct injuries, the zone of injury is important in determining how you're going to attack the repair. And so it's actually it's very straightforward. And so it's, it's a classification system. It's elegant because it's straightforward. So zone A is essentially the intraparotid portion of the parotid duct. And then zone B is the portion of the duct that's most vulnerable to injury because it's outside of the gland. It's the part of the duct that runs along the masseter muscle. And then part C is the part of the duct that is anterior to the masseter muscle as the duct turns into and pierces the buccal mucosa and enters the mouth. Knowing where the zone of injury is important in deciding how can we repair this problem. Zone B injuries are typically most amenable if there hasn't been a significant amount of tissue loss to kind of direct repair. So we're using microvascular techniques just like we would in a free flap or in a neurorrhaphy. So using those very specific instruments. What's important about the finding a stent, and that's why it was great to collaborate with Dr. Walvekar, is that you have to, this is a thin-walled structure, so it's almost like repairing a vein in a free flap. It's not the wall of the parotid duct isn't as thick as, say, an artery. You have to make sure that you have a stent in place so that you don't back wall, right? In other words, you don't put a stitch through the front of the duct and accidentally think you've just gotten the edges together. You've actually gone all the way through, because then you'll have an obstructive problem. So finding the right size stent is really important. We included a table number 1, which lists for the reader the diameter of commonly available materials that you could find in the operating room if you need a stent, if you don't have one of Dr. Walvekar's stents. And this, Dr. Chandrasekhar, this table was prompted by having to have one of our wonderful residents, unfortunately, run around the OR, run up to the NICU and other places to find a stent that we could pass through our lacerated parotid duct. So I said, well, we're not doing that again. We will have a table available to everyone so that they know what you can use. So like you can, epidural catheters are great. In one case we used, I think, a small flexible suction catheter that one of my pediatric otolaryngology colleagues uses when she's doing bronchs and neonates. She passes it through the bronchoscope. So you just have to know the sizes of these things. We have some size parameters in the article so that everyone knows, what the diameter of the normal parotid duct is, so that you can then size it properly. Yes. So these are some of the pearls and tips you were talking about. If you have cyaloendoscopy instruments in your hospital, I think they're also a really great aid in helping to dilate the duct so you can pass a stent, and also to examine edges of the laceration so that you make sure you are identifying the edges properly, not creating a false passage or things like this.
Yeah, I kind of looked at this table and I was like, oh, this is the MacGyver, the jerry rigging.
It's so the MacGyver part of this operation.
Yeah, and I have to tell you, sometimes you drain a cholesterol granuloma of the petrous apex into the mastoid, and the thing that fits in there is a 22 gauge angiocath as a stent. So
right.
I think having this information so that you're not running like a chicken without a head, but you're running like a chicken with a head, trying to find the right stent is, I think, very, very beneficial. We've talked about zones A, B, and C in parotid duct injury, and you included a very nice article from Grady Memorial in Atlanta, Georgia, which to me is like this most magical place. I have to tell you, like someday I'm going to get to Grady Memorial and I don't even know if they're going to let me in the door, because I find it to be a very magical place. But penetrating trauma of the
Mm,
face and neck is I trained at Bellevue in my residency, and
right.
so the Knife and Gun Club was out in full force every weekend. And those zones of injury are really important, and maybe you can talk to us a bit about just cementing that idea in our heads.
Sure.
And then what are the hard and soft signs of head and neck injury, and why should we care about that?
Right. So yeah, so the team that wrote this article was led by Charles Moore, who's on the faculty at Emory, and I think he's still the chief at Grady. I was so impressed with this article because it is so evidence-based, right? I think Dr. Chandrasekhar, I think we all read the same textbooks about zones of injury when we were interns. And when you had a penetrating neck trauma, you were always like flipping through your Bailey's or whichever, your KJ Lee, whichever textbook. It's like, okay, wait, is this zone 1? Is it zone 2? Which is it? What should I be thinking about as I'm running to the emergency room? And I think that is a classification system that served us well for a long time, because it helps you think about, all right, am I doing imaging first? Am I just going to the OR because I will get more information from an exploration than I will, waiting for imaging? How am I going to get all the tools to make the diagnosis that I need? So I think Dr. Moore and his group said, yes, this is a classification system that's been helpful and helps us to make decisions, but maybe this is also a classification system that we need to put into a more modern context. Again, because we have better imaging tools now, right? That having a CTA, even better resolution CT scan imaging at our disposal, I think allows us to get even more information before we're taking someone to the operating room. So that was a recommendation. When I read this, I was like, oh, this is a shift in an evolution in thinking a little bit. Outside of the maybe what even seems like kind of rigid, zone 1, zone 2, and zone 3. And I think what they've talked about is, in adding to that, they have a section on page 1017 called No Zone Systems Based Management. And when I read that, I thought, oh, wait a minute, this is this is going to challenge the readers to just expand their thinking on this topic, right? And so they kind of break it down, not outside of the more rigid zone classification, to thinking about, all right, so is there a vascular injury that I'm worried about? Let's talk about the laryngotracheal issues that may be going on. What are the neurologic injuries that I should be concerned about based on the examination? And then they also talk about penetrating trauma of the face. So I really like that, because it forces us to think about function, and then who are the groups of surgeons that need to be involved in the exploration, right? Because again, sometimes these are very high stress initial assessments, right? If someone has a vascular injury and they're bleeding, but at least if there's a pause and a thinking like, okay, well, if I'm worried about a laryngotracheal injury, then when the otolaryngology team is here, we need to have a thorough conversation with them about how are we going to manage the airway, right? Or maybe intubation is not the best first step. Maybe a tracheotomy is the best first step for this person. Should we be thinking about and prepared to examine the airway, a direct laryngoscopy? Should we, while we're there, like, let's, again, I think one of the themes of this issue and our conversation is preparation. Even in a highly acute situation like this, there's always time for that. Even if it's a very fast conversation as you're wheeling the person to the operating room, so that we're avoiding as much as possible return trips to the OR, misdiagnoses, things like this. And with with articles like this from Dr. Moore's group, people that read this will then be thinking, okay, I have an idea in my head about a protocol that's going to help me when my pager goes off the next time, or my cell phone, because I guess people have done away with pagers.
How old are you, woman?
All things die hard. But people will be thinking more about some of these evidence-based approaches that expand how we're doing our initial assessments and our initial treatment. Now, in many of these cases, of course, you'll have to go back to the operating room, maybe more than once, but at least there's a thought like that we're thinking several steps ahead. I think that's what I really like about this article. And, again, that these injuries they involve conversations across specialties. And I think the degree to which articles like this encourage that, in my institution, and I think in many, the trauma surgeons, the general surgery trauma surgeons, often have an important role to play in the management of penetrating neck traumas. And I think there are opportunities for crosstalk between us, with them, with our anesthesia colleagues who have an important role to play in the airway management, with our nursing teams, with everyone, with our ER colleagues. And so, when we're talking about that, and your question about hard signs and soft signs, that I think is also important for people. Yeah, table 2 in that is important for people to also understand in terms of the acuity of certain patients. Like, does this patient have to be rushed to the OR this moment? Do we have some more time to do an assessment, do a workup? Should we be sending someone to the CT scanner who whose stability is, we're still figuring that out? Are there signs that would point you to airway instability? So some of the things that they list are, stridor hoarseness, massive hemoptysis, impaired speech. I mean, these are things that to an otolaryngologist, you say, of course I would, scope this patient. Of course I would look at the larynx, but I think it's important to remember that that's how we think. This is our training. And it's not always, those connections aren't always made in the same way for some of our other colleagues who are involved in the early assessment. And so that's why we should all be talking in those early stages, so that certain things are not missed. And it's nice that they listed some of these as hard signs, which sometimes get put on the soft side list. Oh, wait, hoarseness, why is that a hard sign? Because that could mean that someone has a recurrent laryngeal nerve injury, that they have a major vocal cord hematoma. All of these are things which, if you miss the opportunity to do that assessment before someone's in the operating room, this is what leads to the delays and the, oh my goodness, how was that? How could we have not, detected that? So, and then the soft signs are, dysphonia. I mean, I think some of the soft signs actually are things that would, again, immediately put someone in the less acute category. This is someone that's probably, if they're brought in by ambulance, they're they're stable, they're talking on their own, they're not needing ventilatory support, they're maintaining their vitals, and so those are patients where there may be something serious going on, but you have a little bit more time to do that assessment. And again, I think that it's the conversations with the emergency department to help them understand, let's just take a quick pause. I can do my assessment in like literally 5 minutes, and I can give you a lot more information that you need to have in triaging this patient.
Yeah, and I think you alluded to this multidisciplinary team. And so sometimes in otolaryngology, when we talk about multidisciplinary teams, they all meet on a Wednesday morning, or they have some time. This is a very acute, hurriedly put together team of experts in each of their individual fields who need to work together. And I really, really enjoyed your article on the perioperative management, I actually very much like that figure of the inline stabilization of the neck
Oh, yeah.
during intubation, because that
Mhm.
picture is really worth 1,000 words. Because obviously you should be there, the otolaryngologist should be there, the anesthesiologist should be there, everyone should be only and 100% focused on obtaining the airway at that moment, right? And I think that picture conveys that so well. One of the highlights of that article of yours is what to do with patients. As you said, sometimes we make wrong choices in life, and that leads to some trauma, whether it be blunt or penetrating.
Mhm.
So what do we do when somebody's has just used cocaine or
Mhm.
marijuana or methamphetamines? Like, what do we do? Because we have to take care of the patient. The beautiful
Right.
thing about being a physician is we don't pass judgment on people. That's somebody else's job. Our job is to take care of you and
Mhm.
to help you and counsel you. So how do you act differently in a trauma circumstance when somebody's actively just used a bunch of drugs?
Well, the idea for this article was born out of, real experiences trying to answer that question and have a good evidence-based answer to that question, right? I mean, again, I think that, so much of what we do in medicine, and I think what I find exciting about what I do is that we are continually learning, right? Like something that we learned 15 years ago was right at that time, but then we're pushing ourselves to think about questions differently and then doing better based on that evidence. And so that's how this article was born, because um, there are patients who come in who, as you said, the trauma and the high risk behavior is fueled by, or there is contributed to by use of illegal or legal substances to excess. So yes, and that will have an impact on almost every stage of what you want to do for that patient, right? It has an impact on your ability to initially assess them, right? If they're inebriated or they're intoxicated, you may not be able to assess them right away. If they have used a substance that causes morbidity, they may have other issues that need to be managed, right? If you have cocaine intoxication, you may have some major cardiac issues that have to be managed first before the trauma issues can be addressed. And then many patients that come in, if they admit to having used drugs or if there's a history, will get a urine tox screen. And that's when the conversation then has to look at, well, okay, if this person is positive for this, how does this impact the timing of what I want to do surgically? If I expose them to general anesthesia when they still have drugs on board, how does that have to inform the conversation that I have with them about the surgical risk? One of our hospitals has a policy about what to do if someone, let's say, is cocaine positive. Do all those patients need to have cardiac clearance beforehand? I think the evidence actually suggests it doesn't. We quoted a couple of articles on this. And again, I think I was a little bit surprised because in the past, my experience had been very much anyone who's cocaine positive, you have to wait until they're cocaine negative. And actually, the evidence suggests that that's not the case. The UTOX tests a metabolite of cocaine. It's an inactive metabolite at that point. The half-life for cocaine is actually pretty short. And once it's metabolized, even though it's still detected by the test, the patient may not be under the influence anymore. So I think, that knowledge should inform kind of what we're doing surgically. And unfortunately, it hasn't, so there's still many places who tell patients until you're tox negative, no surgery for you. But the problem there is that many of these surgeries are time sensitive. So if your UTOX is not negative for over a week, which that could happen if the metabolite hangs along around, then maybe you miss a therapeutic window. And so some of the guidelines that we've quoted in this article suggest that we're thinking about this a little bit differently, and we're separating patients into those that are like cocaine intoxicated versus patients who may have used cocaine, but who we've assessed and who we know are not at risk for cardiac issues intra-op. And that might involve having the patient have something just like an EKG, and that's it. Or if there's something more you're concerned about, then maybe an echo. But I think the assessment can't be a one size fits all, right? It has to be a little bit more individualized to what the patient needs, so that they don't miss these therapeutic windows and miss out on treatment, and then have to have something secondarily.
This points to emergent versus urgent versus elective
Right. Yeah,
interventions.
it
And
does.
again, it's the team mentality, right?
Mhm.
I remember, in training, just somehow we were all enemies. And I'm like, I don't understand why this service is the enemy of that service is the enemy of that service when we are all in the service of the patient in front of us. And I think that has definitely evolved over time with anesthesiologists, vascular surgeons, general trauma surgeons, head and neck trauma surgeons, everybody sort of working together for the benefit of the patient where we meet them. And I think that's really very vital. And I think that's something that you cover beautifully. So there are many more articles in this issue of Otolaryngologic Clinics of North America that we have not discussed. And they include articles on temporal bone and larynx trauma, on orbital fractures, details about soft tissue trauma and how to deal with it. So I encourage our listeners to go back to the issue and read all of the material in it. It's really a treasure trove of current and, as Dr. Butts says, evidence-based information of what we know and why we know it, and what's the best way to treat these patients. So once again, I'm Sujana Chandrasekhar. I'm the consulting editor of Otolaryngologic Clinics of North America. And today I've been speaking with Dr. Sydney Butts, who is the interim chair of otolaryngology head and neck surgery at SUNY Downstate Health Sciences University in Brooklyn, New York, about the December 2023 issue of Clinics, which she is the guest editor of. The issue is focused on otolaryngologic trauma, and you can find the entire issue and individual articles at www.oto.theclinics.com. And that's where you can find a podcast per issue. And you can find all of the supplemental materials like the video that her team sent in for this issue. You can also find the podcasts wherever you get your podcasts. As always, thank you all for listening. Please reach out to me if you have ideas for future issue topics and how we can make our podcast better. And thank you so much, Dr. Butts. It is a joy to be your friend and your colleague. And it was truly a joy to watch as you created this issue and today to sit and interview you about the contents of this issue.
Thank you, Dr. Chandrasekhar. I'm as I said at the start, was very honored to be invited to be a part of putting this together. I'm so pleased and grateful that Otolaryngology Clinics decided to dedicate an issue to this. So important topic. And I think, I'll just circle back with two things, maybe, in my intro to the issue, I quoted an article by our colleague, Cecilia Schmalbach, at Temple, and she surveyed recent otolaryngology clinics. She published this article in the White Journal several years ago, and she was interested in understanding what the recent graduate otolaryngology workforce would be interested in doing in terms of their involvement in head and neck trauma, right? Because we all know that it's acute care, right? It's on-call care. It's sometimes care that you feel is undervalued, right? You don't always feel appreciated for this kind of work. And it can be sometimes under the radar. And so knowing those things, certainly I think her article was driven by perhaps a concern about whether graduates of training programs will do this in their chosen sites of practice. And so what was reassuring about that article was that many of the respondents said that they felt that they had been well trained in head and neck trauma, right? You're not going to do something if you don't feel that you've had enough exposure and experience with it. So that's, I think, saying something really good about our training programs. And then that the physicians who responded also felt that providing head and neck trauma care they felt a sense of duty around that. And when I read that in the article, I felt very, I felt a lot of pride. And I also, because I know that means that there are colleagues or faculty that are training our residents who have shown sometimes, even when they feel it's a thankless moment, they have shown actually the value in this work and that it's coming through, even if you don't feel it in the moment, that someone does. And that I think some of the most important people do, who are the residents that we're training, and I think also the patients that we're helping. So that's why I wanted to include some of the information from Dr. Schmalbach's article, because I hope that it serves as motivation for those of us that spend a fair amount of time taking care of patients with facial trauma, and wanted to include that because as a way of kind of saying thank you to every author that contributed to this issue. I think it says a lot about how they are models and mentors for patient care and for making sure that otolaryngologists continue to play an important role in facial trauma management.
Beautifully put. Beautifully put. Thank you so much, Sydney.
All right. Good night. Thank you.
Thank you for joining us for this edition of the Otolaryngologic Clinics podcast series. For an exclusive discount on the issue we discussed today, focusing on otolaryngologic trauma, visit us.elsevierhealth.com/expert. Otolaryngologic Clinics is available for individual print subscription with accompanying online access or individual online-only access, and is also available on the Elsevier electronic platforms Clinical Key and Science Direct. For more information on this series and our nearly 60 other titles spanning all medical disciplines, visit info.theclinics.com. Be sure to follow us on Twitter and subscribe to the Otolaryngologic Clinics podcast wherever you get your podcasts.